You're listening to The Fully Booked Therapist with Heather Hommel. This is the business coaching show for hands-on therapists who are done under-earning and ready to build a practice that pays them more than enough. Real conversations, real results, your real life. Let's get into it. Hey, everybody, and welcome back to another episode. Today, I am joined with Brian Tuckey. He is the creator of Fascial Counterstrain. Brian, do you want to kind of introduce yourself and give us some of your background information?
Sure. Yes, I'm a physical therapist, PT, OCS, board certified specialist in outpatient orthopedics. I am one of only 4 physical therapists that the famous osteopathic physician, Dr. Lawrence Jones, certified to teach strain and counterstrain. It's this technique's predecessor. I was certified at about the age of 25, 26 in the mid 1990s. So that makes me old. I've been practicing now for 36 years in the manual therapy and osteopathic manipulation world. So after Dr. Jones passed away in the late 1990s, I kind of took over the reins of innovation and really expanded the technique from 200 techniques that were just find the tender point, treat it, and we didn't really know what we were doing, to what is today over 1,000 techniques that has both a diagnostic process, anatomical correlation to what those tender points mean.
That's amazing. What do you think gave you the audacity to go from being one of 4 people trained in this method to basically creating, you more than quadrupled the amount of treatment options available. What were you thinking at the time?
So I would say of the 4 of us that were certified, I was by far the youngest, but I would say that they were really not at a point where they really were being inquisitive as to what exactly we were doing. And I always had the mindset that this technique can't reach its potential if we don't understand the mechanism and we don't understand what we're actually treating. Now, in their defense, including Dr. Jones for sure, the amount of information on lymphatic science, pain science, fascial science at that time was very limited. We had one article. It was the 1975 core article, and it was proprioceptors and somatic dysfunction. That's what it was called. And that was the only article that came out that said with chronic dysfunction, joint dysfunction, whatever you want to call it, myofascial trigger points, there is something wrong with the proprioceptors. And it wasn't a scar tissue thing, which was really the paradigm at that time. We got to pop the scar tissue and everything will line up.
Yeah.
And so, and Dr. Jones grabbed that and he said, this, proprioceptive dysfunction is the only thing that can explain what he was doing. And for those who don't know anything about strain counterstrain, Dr. Jones was an osteopathic physician, which again, he was functioning as a primary care doctor in Ontario, Oregon, but he was trained in manipulation. So when his patients would come in and they had various musculoskeletal complaints, he would use manipulation, but then he might also check your blood pressure and, give you something for your cold. So a guy came in who had seen 2 chiropractors previously for 6 weeks each. And he had, a pretty significant flexed vertebra at L2. He was stuck bent forward. The osteopaths will call that psoasitis because there was a psoas spasm, which, as you guys would know, attaches to the L2 segment. And he couldn't stand up straight and he was in severe pain. So these chiropractors each did a manipulation course of about 6 weeks apiece. And, eventually just sent him to Dr. Jones. He was like, well, this guy knows some different stuff. And he's the only other person that's in town that treats backs. So Dr. Jones, when he would tell the story, he would say, he did about 5 weeks of manipulation before he finally admitted that he wasn't helping the guy either. Mm-hmm. And he came in and said to Dr. Jones, I think I could respond if I could just find a position to sleep. So at that point, Dr. Jones said, yeah, makes sense. So he started to experiment with positions of comfort and found bent up with his knees rotated off to one side, his pain stopped. So Dr. Jones kind of used pillows and propped him up in that position. And he said, okay, we'll stay here a while so we can see if you could really sleep in this position. Took off, treated some more patients, came back about 20 minutes later, guy gave him a thumbs up, said, feels great. And so he took all the pillows out. And when the guy stood up, he stood up perfectly straight. which he had not done. So then they both kind of looked at each other, and Dr. Jones said, "What's going on?" He goes, "I don't know, that sharp pain isn't there."
Hmm.
He checked his range of motion, and he even gained about 50% of his extension back.
Wow.
And, they're both kind of dumbfounded. And he's like, okay. So when he came back several days later, he walked in upright and he said to Dr. Jones, I don't know what we did there. He said, but, I can live with the remaining pain. It's not much. Dr. Jones then assessed him and saw that L2 restriction was gone.
Hmm.
It was no longer flexed. So he was a very intuitive guy. So, with that, he said somehow pain-free positioning fixed a dysfunction with a lasting effect without any force.
Hmm.
So that was one of the first non-force indirect, manipulation, I should say, observations. Later, he started to correlate that there was tenderness to each one of these restrictions, and he could position the person to where that tenderness went away. That's how the tender points were mapped out, and ended up mapping out about 200 before he passed away. So,
Wow. That's
yeah.
incredible. So then when you took over and started developing fascial counterstrain, like what were you thinking? Like you said, you were the youngest out of the 4 other therapists that were certified.
Yeah, so I had been exposed to manual therapy before I even went to PT school. I
Okay.
happened to volunteer for a bunch of different people. Initially, I wanted to be an orthopedist, and my mom was a nurse, and she had me interview with a couple of those guys, and they did not like their jobs. So I said, okay, I won't do that. So anyway, I happened to just try several different clinics, and I ran into a guy, you can call it coincidence, God's providence, whatever it was, that was a high-end osteopathic manual therapist, and he was in my own hometown. And when I watched him work, I mean, he was just, people were limping in and walking out and turn their necks, and everyone else was just TheraBands and bikes and ultrasounds and stim machines, didn't do anything. So finally I said to this particular guy, I'm like, I'm volunteering in a lot of places, and, no one's doing what you're doing. And he's like, well, I'm not doing PT. It's actually osteopathic medicine. So I said, wow, I would love to do this. He's like, well, let's keep in touch. When you get through school, tell me and I'll point you in the right direction. So I even in PT school, I was taking osteopathic classes at night on my own. Yeah. So even when I got to my residency or my clinicals, I already knew muscle and energy for the whole body. So anyway, studied at Michigan State, studied, Travell, studied, Upledger, all over the place. Mm-hmm. When I met Jones, again, it was just because one of my, student people I met in training said, you got to try this stuff. We were, I was like, what the heck?
Yeah.
I didn't go in with any major expectations, but his ability, and Randy Kusinosi, who was, one of the first guys certified, they were teaching that class, how fast they found dysfunctional tissue, the way they would change the body, they were going indirect. It was just blowing my mind. Mm-hmm. And my lab partner, I've always been an athlete, and everywhere he found tender points, there were places that I had chronic pain.
Interesting.
And just the depressed rib dysfunctions, which I know today are cartilage of the costochondral cartilage. I had a 1-2 dysfunction, and that gave me my shoulder flexion back because I was stuck, kyphotic. Yeah. And my tendonitis disappeared just from what my lab partner did in the first lab. So I was like, all right, I think I'm going to try this. And, so I was doing several other things at the time. I was studying at Stanley Paris's curriculum. And, it was kind of like speed dating, right? I was just like, who do you like? And, kind of fell in love with Counterstrain.
I love that.
Yeah.
That's like such an interesting story. So you fell in love with it. And then after Dr. Jones died, you decided to take it further. I mean, you have to really be bought into this method this is become your life's work now. Did you say you developed over 1,000 more points?
Yeah. So I developed the entire diagnostic process we use today, including what's called the cranial scan.
Okay.
Which is an embryological motion test of the cranium, which tells you which systems. Well, let me take a step back. This is a whole course of talk we're trying to do here. But so in the end, what tender points are, it's a sensory secondary, cutaneous hyperalgesia presentation of a deeper problem. Mm-hmm. Okay, so they're diagnostic. So back in Jones' day, it would be like sternum 3, T5 on the T5 posterior. So now I anatomically correlated every one of those to its source tissue.
Wow.
So, you want to treat the external iliac vein, I can tell you what point on the surface is the external iliac vein.
Wow.
And then to take that another step, I developed a cranial motion test that allows you to, for example, the mastoid process, if you motion test the mastoid process, it tells you about the peritoneum and the pleura. It tells you about the viscera.
Wow.
So if that's rigid, depending on where it's rigid, you know they have visceral fascial dysfunction, and you know approximately where that tender point is before you start.
Wow.
Go through the whole way into the end of the curriculum. There's almost 100 quick motion tests that we do.
Okay.
So it's got a full diagnostic process. So there is no guesswork. The body tells us where the primary problems are, and we just follow the process. And the tender point will disappear, but it's also just an indicator that you fixed the deeper structure. Okay, so
Yeah.
all of that I developed over all these years, and it's I'm still doing it.
Right.
I still see patients to this day. But what I would say as a nutshell, because I don't want to lose your listeners, if you look at the success that you're having doing myofascial release, you have to realize that myofascia is just one system or subsystem of the entire fascia continuum. Okay. So if you look under a microscope, myofascia and vascular fascia and neural fascia and visceral fascia, ligaments, tendons, they all have the same proprioceptors. They all have the same, myofibroblasts, contractile tissues. They all have neurons that connect into the spinal cord, and it's a proprioceptive organ. So fascial counterstrain is multi-system.
Yeah.
So we treat, and the classes are broken down into visceral class, lymphatic and venous class, arterial class, and you learn system by system.
But ultimately, they all affect each other all the way down to
Yes,
the cellular
100%.
level. Yeah.
100%. So in the end, what happens is that, yes, you can treat pain and range of motion indirectly. It's pain-free. You just shorten. We'll talk about how it works. But you also, the scope of your practice expands dramatically. Today, for example, I just got back from practicing. I had some full body global pain patients, but almost everybody I saw was not a pain patient. They were coming in for, visceral dysfunction, brain fog, balance, chronic fatigue syndrome, one little boy with developmental delay. When you start to be able to work on, blood flow in and out, like post-concussion syndrome. Okay. They're foggy, they have headaches. That's swelling in the drainage system of the brain and the lymphatic system. So release those, drain that out, things like photophobia, even anxiety, all these things change if you can take the inflammation out of the brain. So the scope of the practice, it gets really big, which is a great thing. Everybody's got something going on, and you can treat digestive stuff. So it's not just a pain practice at that point.
Yeah, that's very interesting. As far as like the training goes, do most therapists go through several classes before they start treating patients, or are they able to, like, after the first level or however you categorize these, get into treatment and start putting these into practice with their patients?
we recommend you go back and you start doing it, and you 100% fall back on whatever your wheelhouse is.
Sure.
But if you want to integrate it, so in foundations, it's basically kind of a appetizer. So I'll go through the physiology behind it, which we can get into that, but there's very hardcore science behind this now.
Sure.
Why it works, how it works, what's an indirect versus direct. Then we go into a bit of the diagnostic process, teach you some of the embryological cranial scans. And then for each assessment we give you points that you can actually treat. So you'll come out of the first class with 40 different techniques from 5 different anatomical systems that you can go back and start practicing the skills. So for example, you'll learn how to turn off the preganglionic sympathetics, the ascending ones from T1-2 that make up all the sympathetics to the entire head. Well, when they're dysfunctional, it causes vasoconstriction of all the vessels of the head and brain. So a gazillion techniques with one right-left release. And you can open up all the drainage and improve blood flow. That's in beginner class, just an example of the nerve stuff we teach there.
That's amazing. So even as a beginner, do you feel like therapists are able to make a difference and make headway with their patients, even without like maybe knowing how to do it perfectly?
Yeah, because we want you to eventually get to the point where you are in the myofascia, where your hand is there and you already know it's an ouch before they say ouch. You follow me? So we want it to become objective, but you have a diagnostic tender point, and once you make that diagnosis, it's a cookbook. You got the picture, you got the flex them, turn them, side bend left, rotate left, and you're going to check that tender point. When it turns off, you start your hold, and you hold it for about 45 seconds. So
Okay.
you can do it right away. The more manual therapy background and experience and how trained your hands are, the faster you pick it up. People who have myofascial experience are going to have a lot of the skills already. So
Yeah.
they just need to understand the science behind it, the physiology, versus like a doctor, the physiology might be like, I got it, but then they may not have the hands.
Right.
So,
Yeah.
like anything, there's a bit of a learning curve, but the techniques, if you follow the diagnostic protocol and the cranial scan and the tender points collectively, when they match, it tells you that's a source inflammation. And I'll get into the science a little bit, but there are some research articles that we'll talk about at the end
Mhm.
that if you really want to, hear the real science, don't listen to a podcast, just read the article. I
Yeah.
published the method article, I call it. So what is fascial counterstrain? I published that in the International Journal of Osteopathic Medicine in December, of last year.
Congratulations. I mean, that's kind of a big deal to get published
Yeah,
like
yeah.
that.
The only way you could get that published was because getting a manual therapy technique, a new technique, there's no category.
Right.
So that journal had what they call a masterclass category. So if you're a quote unquote master clinician, you can write the editor and say, my one research doctor friend, I said, well, how do I get in that? He said, well, you tell them what you want to write and you tell them why you're the person to write it. And if they agree, then they'll let you submit.
Yeah.
So anyway, they just say, okay, we'll read it. That doesn't mean they'll publish it.
Right. Well, and how much work goes into writing that research paper?
Well, the one we'll talk about more is the one, since this is effectively a inflammation drainage technique. So if you said, all right, Brian, elevator talk, what is fascial counterstrain?
Mm-hmm.
I would say it's a complex process that identifies and removes trapped inflammation from the body.
Mm-hmm.
And it is that trapped inflammation that drives the muscle guarding reflexes, the tender points, it drives the whole thing. So I had to, and that's what we do, we decompress and hold, but that was not in the research. Okay. They did in 2007, did some interstitial sampling studies. And there was a guy by the name of Jay Shah. He went at NIH, they developed a microdialysis needle. They went into active trigger points, and it was a tiny little needle that could draw out the interstitial fluid, not the blood, the clear stuff, right? The blister fluid, and
Yep.
check it for cytokines to see if there was inflammation compared to the other side that didn't have a trapezius trigger point. Turned out there were 23 different types of inflammation and catecholamines and things in there. He got that idea because he was one of my patients, and I
Mm.
told him to do it. And
Yeah.
he's now world famous, Dr. J.P. Shah, if you go to fascia congresses. But anyway, so they sampled it and proved it was in there. But nobody could say, how did it get there and how does it maintain? Well, that article, the title is Impaired Lymphatic Drainage and Interstitial Inflammatory Stasis in Chronic Musculoskeletal and Idiopathic Pain Syndromes,
Okay.
exploring a novel mechanism. So we can get a link to this, but
Yeah. We'll have all the links in the show notes, so nobody
yeah, so
panic.
impaired lymphatic drainage, Tuckey, it'll pop up
Okay.
and you can read it. But that article is 147 citations, 6,300 words to
Mm.
explain how it gets trapped.
Yeah.
And that article was in Frontiers of Musculoskeletal Pain in 2021. It is now by far the number one most downloaded article in that journal all time by it's got 60,000 downloads, and number two is like 22,000.
Wow.
It has at least 35 citations, and your average like PT journal, the average thing gets like 2.3 citations.
Mm-hmm. Yeah.
And here's what's really cool this week, which just happened before I came online with you here. That impaired lymphatic shutdown stasis model.
Yep.
There were some scientists in China that, using all the latest technologies, 3D imaging, we're talking sampling and dye studies, they tested it. And they just published in basically one of the Nature journals, which is the number one journal in the world. They just published their findings and they tested it on the TMJ, and it was correct.
Wow.
So they actually said basically that this hypothesis was proven in the TMJ to actually happen. So it's no longer a theory, and the only place they tested it, it was true. And
that's
that was
amazing.
And I have that citation here, but that
when
was
do you
just
think medical school will get caught up on teaching about fascia and like all of the differences that
Yeah, it's a good question. It's kind of like, why don't they really teach a lot of this stuff? And the answer is they don't have anyone who can teach it.
Well, and they're behind, right?
And they're behind, right? They're using textbooks that are, like
50 years behind.
50 years behind.
Yeah.
When
My
I'm,
husband's an osteopath. So and
oh,
he's always
okay.
like,
Yeah,
oh,
yeah.
I know what MFR is. And I'm like, no, you don't actually.
Yes. Yeah. No. And the osteopaths they know the old Jones. They don't know this.
Yeah.
But yeah, so like I literally, even in my foundations class, I changed the lecture of it, every year. All my
Cool.
classes, I update them every year for the latest research.
I think that's really important. That's really important work that you're doing and taking the time to do that. That's awesome.
Yeah, the stasis paper, and again, I had Dr. Shah and another very well-known researcher, Dr. Serberly from Canada. He's a neurologist. They were on the paper, but we would do Zoom meetings. I would do the work, the writing, and then we would Zoom on Saturdays. But that took me over 500 hours.
Wow.
And you don't get paid for it.
No.
Right. So like I said, you spend a lot of time. Matter of fact, at the end, you've got to pay to have the article published to make it open source.
Sure, of course. Why not?
Yeah. So like I'll spend $500 and I pay $3,000 to have it published. So, or have it printed so that you guys can download it.
Yeah. Wow. That's a lot of efforting to go into that. But I think people can be really thankful that it's available, and hopefully it will start to turn the course of, medical care and treatments for patients that have chronic or unexplained pain.
Right. If you want to, and this is kind of your original question, why did you get into the science and, just not just do Jones?
Yeah.
If you cannot describe the mechanism with published known physiology and you don't have a mechanism, then you'll never mainstream it. So first have a real mechanism that stands up to scrutiny. Then number two, start to do real research. So we've done case studies. We published one last year on PTSD, treating the sympathetic nervous system.
Yeah.
We did, one of my doctor friends just did one. She's a pediatrician who counterstrains. She did one on bedwetting, and kids, treating the spinal cord. So we're pumping them out. I did one on sciatica this year. But that Chinese one was very cool because it said the whole theory appears to be correct. Okay.
Yeah.
And so that really leads back to why are we able to treat central sensitization? Because we can drain inflammation even out of the central nervous system.
Wow.
Do you follow me?
Yeah. I mean, it sounds like something everybody needs too, like just from being alive.
Yeah. You won't have a problem with patients. Yeah. I mean, I saw that. I looked on your podcast there, and again, trying to help people become successful and get practices, which, it's a business, right? It's, you don't have patients and you can't do it.
Yeah.
But a lot of, I'll just give you a quick, case of a single mother massage therapist I met like 2.5 years ago. And, she had the work done. She's like, I want to do this. I don't have a lot of money. She's like, what do you recommend? And I said, she's like, should I go back to school and take a loan? I'm like, no, don't do that. Right. I'm like, you already have license to touch. I said, travel, the whole course, everything. It's under $1,000 a course. I said, take $5,000, even if you have to borrow it, master 5 classes. I said, and you go beyond that, you'll have a wait list. Well, I caught up with her about 6 classes in. I don't teach all of them anymore. I have people specialize, but I teach the beginning, I teach some in the middle, and then I teach a lot of the end stuff, the newer stuff. But anyway, she has like a 6-month wait list. She's charging like $150, $200 an hour out of her house. I mean, don't go market, just get skills, and your patients will fill you up.
Yeah.
Right.
Yeah. Or get the skills and then come to me and I'll help you get full even faster.
Yeah. Well, there you go. That's right. Let's teach you how to market your skills. But a lot of it, you're competing. If you're just doing musculoskeletal work, there's a lot of competition for that.
Sure.
But if you're like, hey, I can treat, fibromyalgia, I can treat chronic constipation, I can treat, your scope is so big, no one else has anything to offer those people.
And also if you have the results to back it up, right? Because anyone can say, hey, I treat these things, but I want to know what your results are. I want to know how successful your patient outcomes are, right? And leaning into that a little bit, how much confidence does it take, like for that massage therapist to maybe specialize in fascial counterstrain versus identify as a massage therapist? Like, do you feel like people walk away from your foundations, learning the techniques, and they embody the therapist that you want to be out there with your name on their work? Does that make sense? Like, how much confidence does it take to be able to recreate that?
No, that's an excellent insight, excellent question. So, I worry about these things being the person trying to, hit this up.
Your name's on it, right?
Yeah, my name's on it. So we don't even allow people on our Counterstrain search engine until they've taken at least 4.
Okay.
And then we work as a community. So if somebody walks in, one of these high-end chronic pain, full body central sensitization patient, and you're like, hey, I'm pretty good with musculoskeletal stuff, but I tried what I did, it didn't do it. We don't say, oh, well, Counterstrain can't help you. You say, well, there's a few people who have a bit more training. You may have to travel a little bit, and then we work as a community. So
Yeah.
like my entire caseload, because I wanted to finish the central nervous system people. So
Mhm.
I'm pretty much, I take patients by request email, and they need me.
Mhm.
You follow me? Or I'll say, no, you got someone in your own state, go see them, or come see one of my
Yeah.
colleagues. So I'm treating like, Parkinson's and traumatic brain injuries. And, so that way, a lot of them have already seen my students, and hey, that's the first thing that ever helped me, but I'm stuck here. Then they'll
Mhm.
fly out for 3 days. I'll do a 3-day intensive, and they stay in a hotel, and then I'll send them back off, and I just keep tabs with them. So I'm able to immerse myself in some of the toughest cases in the country all day long to map out this end stuff. Does that make sense?
Yeah.
But
Yeah. And
anyway,
to continue your research, right? And to continue.
exactly,
Yeah.
exactly. I don't want to treat a sprained ankle, and I know how that goes.
Yeah.
So anyway, we work that way, and patients really appreciate that. And when I send it back, I'm like, all right, I hope I never see you again.
Mhm.
So go back and let your local therapist clean up whatever shows up next. I did a lot of the deep brain stuff, and then they only send them back if needed. So then the person doesn't say, they'll say, well, my therapist helped me a lot, but she thought I needed more advanced training, so I had to travel. And then as that person gets better, less people need to travel to somebody else because you're deep in the curriculum.
Yeah. For people that are deep in the curriculum, is there an actual certification through your programs, or how does that work?
Yeah. So certifications are hard to do. Okay.
Yeah. I would
Manpower
say,
wise, they are hard to do.
yeah.
So, I realized I didn't want people getting all the way up and treating the heart and the brain and the brainstem without knowing for sure that they're proficient in the assessment, because quite frankly, it's not safe.
Okay.
Okay. These techniques, the good thing about it is they're wham, change. Bad thing about it, you do it totally in the wrong order. You could give somebody a flare up, but you're not going to kill them. But like, for example, you did deep brain work, and you didn't know that they were tethered in their dura, in the foramen magnum. You'll clog their brainstem as it tries to get out,
Yeah.
and they'll get nauseous. They could get vertigo. They could feel like crap for like 3 days because you didn't listen to the body.
Mm-hmm.
Does that make sense?
Mm-hmm.
So we do have a proficiency exam, which is about, there's 5, 6 classes in that we call, base level cert or proficiency. That allows you to get into the end of the curriculum.
Okay. So you can't even take those classes until
Yeah, you
you've
got to show us
proved
you
your
can do it.
proficiency.
If you are doing it every day, you'll pass.
Yeah.
But the point is,
That's good to know.
I owe it to those patients that are the worst in the world to make sure anyone who treats them, okay, it should be treating them. Does that make sense?
Yeah. Yeah. No,
And some
I think I can
people complained about it.
appreciate
I'm
that.
like, it costs me money to tell you, no, you can't take my class. I said, it's
Yeah.
about safety. It's about safety.
Yeah. Well, and I think your name is on the work, right? Like you want these varsity level, like people that are really taking the work serious and want to be proficient in it,
Correct.
right? Going further with it.
Correct.
Anyone can walk in and take foundations and,
Sure.
just like put it in their toolbox and maybe never think about it again, or they pull it out on a Wednesday or whatever.
Right. Right.
Your concern is like getting the people that are really into it all the way through the program, but making sure that the basement level has been accomplished and they're ready to go forward with the more
Yeah. And
complicated
I've
stuff.
met a gazillions of therapists that said to me, you know what? I don't want to treat those worst patients in the country. I will send them out.
Mm.
I took 6-8. She took 6-8 classes. She. They're able to treat back pain, neck pain, sports injuries, computer stuff, overuse, carpal tunnel, whatever. But you come in and say, I have chronic fatigue syndrome and I had a traumatic brain injury. They're like, I'm going to refer you out, and they don't even take those classes. They just don't even want to do it. Totally respect that. Yeah.
Yeah. I mean, I think it's better when you want to do it. It's kind of like, I don't want to go to a surgeon that doesn't want to do surgery,
Right. Right. Good point.
So that's okay to know what your limits are.
Yeah, and
Okay.
you've been a therapist long enough that people who have full body syndromes, where you loosen, they now complain of what you didn't get to, right?
Yes.
So, there's reactions even when you do things right, because they'll
Oh,
say,
yeah.
wow, this loosened, but now I feel this. And you can't be a person without confidence and knowledge. You can't panic in those situations.
Mm-hmm.
Does that make sense?
Yeah. 'Cause sometimes you do get worse or you feel worse before you get better, even though you are better. Like your just perception of your condition has changed too.
Right.
Yeah.
Right.
Yeah. How many therapists right now are certified?
Certified, I would say we just started the certification about the time I started rolling out the heart brain level stuff.
Yeah.
And brain one, what we call CNS one, was rolled out to the public this year.
Oh, so it's
And
fairly new.
yeah, but there were
That's
two
awesome.
other, so we had certifications so that people would be ready to take it. So we
Okay.
started certifying people about my teaching assistants around the world and my teachers certified first. And then we did, I think, 3 classes. So it was probably 150, 200 certified people. But there are, I would say real serious counterstrainers, upwards of like 1,000 around the world at the moment.
That's awesome.
And it's growing. Our foundations classes have been, you know, we do 2 a year in 5 satellites.
Okay.
It's called Foundations of Fascial Counterstrain. And it's in 5 cities in the United States. And they've been pretty much selling out lately. So, we'll eventually maybe go to a series of, 3 5-city ones.
Yeah.
But, there's 20, 25 people in the class. In Frederick, Maryland, where I'm talking from now, I take, 26. And then I'm doing all the demos and the lectures from there. And then let's say you go to San Diego, you've got high-end instructor TAs right there with you. We go off camera after demos, and then you practice with the TAs with your lab partner. We come back on. So we do 5 cities at once.
Oh, that's really cool. So you're teaching everybody, but you can be in the satellite
Yep. Yep.
cities with
Yep.
high-end TAs and instructors and get basically the same, like it's just over Zoom or whatever,
Correct.
like the instruction part. That's such a smart business model.
Yeah.
I love that for you. And I love that for your clients. That's so cool.
I even do in the middle of the night, I do lectures to the therapists in Australia.
That's really cool.
So those guys can do the techniques, but they're not ready to lecture on it. So I'll literally do the lectures, and then they'll zoom off in lab, and I'll take a nap, come back,
Yep.
do the next one. So we even do it internationally. Yeah,
that's really cool. I love how you are training other people to teach it, so it's not just all in your brain. So
no, that's not the
that's so
goal.
scary when someone that is trained or is the leader in a method dies and there's no plan.
Oh yeah. Well, Jones used to say to me, we go out to lunch and things, and he would say to me, "You got to make sure this doesn't die with me." So he could tell it was a beginning, not an end. Whereas the osteopaths, your husband can tell you, they're like, "Oh, Jones died, it was over." He never felt that way. He was like, "This has got a lot of potential, and I'm 82 and can't do any more."
Yeah.
And I'm already looking for the next Brian. I'm looking for the I already found 2 or 3 people that are 30 that are hot shots, and so I'm looking.
That.
I always say my goal is to make myself irrelevant. That's my goal.
Yeah. Right. Which is so good. Okay, so I had this question of, what do you see as your legacy?
Yeah, I mean, gosh, I would say that with all due humility, there isn't any, substitute for this work right now. What it does is unique in medicine. But hey, if I also happen to explain, through the research, how chronic pain exists, that would be a pretty cool thing.
That would be cool.
It's all really, the technique led me to a conclusion. But if you want to mainstream the technique, you have to say, this is the problem, this is the treatment, and put it together. And, I feel like I'm trying to get a movement off the ground, and before I burn out or get hit by a car or something.
Yes, right? I mean, we never know what's going to happen tomorrow.
Yes.
But I think that that's really cool, though, to hear you say the words like, I'm getting a movement off the ground. And I think that's kind of how I feel about what I do and who I help, all of the people that are trained in these modalities and these methods, to make sure that they have a sustainable living and to make sure that they're not overworking just to put bread on the table. That's really, really important to me.
Right.
And I also love the fact that you can be the massage therapist that gets fully booked doing this method and didn't have to go back to PT school, didn't have to, create $200,000 of debt to become a doctor of physical therapy in order to do it.
And, as we were saying earlier, what you're learning in those schools, even the anatomy is. Last foundations class, I have a slide that goes through misconceptions about fascia that I learned in school and how it was all wrong. Mm-hmm. And the guy came up to me after class. He said, "I just graduated last year and they're still teaching that crap."
Oh, yeah.
And this was 1990. I was like, this is what they used to say about fascia. He goes, "That's how I was taught." And I'm like, they're 36 years behind in the lecture.
Yeah. It's scary. And then they're operating
which is
on
scary.
People,
Right. And you're paying $40,000 a year for that.
I had to have back surgery a couple years ago, and I was like, be really gentle on my fascia. And the guy's just kind of like, what is wrong with you?
Yeah, you got to break it up. Yeah. No, it's scary. It really is. And even the physicians, when you start to get into the world of the multi-system dysfunction, where that really comes from, people who they literally have a litany of diagnoses. So they may have irritable bowel, they have anxiety, they have chronic fatigue, and
Yeah.
all these different, I have TMJ, I have headaches, I have global pain. And what they all have in common is actually the brainstem.
Mm.
So if you look at the medulla, okay, it has nuclei that are pain nuclei. It has, of course, all your vagal nuclei. It has your rostral ventral medial vagus, which is another part of the fight or flight system. It also has connections to your reticulospinal tract, which is motor, and then it connects into your cerebellum. You follow me? So you can
Yeah.
have,
I'm trying.
yeah, well, you would have heart, digestion because of vagus. You can have
Yep.
fight or flight. You can have tightness. You can have balance disorder. That's just medulla swelling.
Yeah.
So people, and then go to the pons and midbrain and cerebellum, and you get swelling in that area, and your whole body is a wreck. You're seeing 12 different doctors.
Yeah.
And, we go in and treat, a few hours of drainage, and next thing you know, they don't need to see all these doctors. And they've spent, $60,000-$70,000 in tests and found nothing.
Mm.
And,
Wow.
who does look at the whole body and yet understand the anatomy of the whole body? Well, no one is the
Nobody.
answer. Right. That's what I'm
Nobody
saying. That's part
does.
of the
Yeah.
legacy. We should be treating the human.
Yeah.
And, now it's a lift to understand the anatomy and physiology of every system. So I'm not going to lie, this work isn't for everybody.
Mm-hmm.
But, the people who do it absolutely love it. And then
Yeah.
there's some people like, wow, that's a little much for me. And I get that.
Can you also learn it and do it without having to have like all of those medical terms? Like, do you have to know deeply everything about all of those symptoms, or can you know enough, or those?
You go through the lymphatic, venous 1 and 2, which we recommend you
Yeah.
take next, and musculoskeletal stuff. You already know those things. Like
Yeah.
you'll be treating myofascia. I have all the myofascia done the way the structural integrators do it with Myers chains. So I
Mm-hmm.
found a release for each entire myochain. So he calls them
Mm-hmm.
anatomy trains. I call them myochains. So literally one release, gone, done, the whole thing.
Mm-hmm.
So, you can take classes that do spinal ligaments and myofascia, and anatomy is not complex.
Right.
But if you want to go up and treat the brain and brainstem, those are for the anatomy geeks like me.
Okay. Because then you really want the heady stuff, and like you want to be able to regurgitate all of this information.
Correct. But you don't need to know that to do what most people could see in their regional practice.
Sure. Okay. And
It's
even
only,
as you start out though, and like some of these terms become more familiar and you get more I like to call it nerded out into it, maybe you start to relax around some of these terms and some of the headiness of it. And you start to believe that you're the kind of person that can do these things and can learn it, even when it seems difficult, just because it's new, right? It's like terminology that's newly introduced is always going to give some people anxiety, or they're going to think I have to be perfect at it, but you don't.
No, you don't. No, you don't.
Yeah.
And your hands get, or 90% of it.
Yeah.
It comes down to, if you follow the motion testing, find the tender point, you could do great stuff. You may not understand the why. The person says, wow, when you did that went away. You might, okay, I don't know why, but you did it because you followed your hands the way we told you.
Do people have like emotional responses to these treatments in the same way? Like we're taught like unwinding and myofascial release. Like, do people have those interesting responses?
100%, because when you start to look at swelling, it's called neuroinflammation. And that is the medical term for inflammation in the central nervous system. Okay. Mm-hmm. When it gets into the areas of the brain, what physiologically happens is inflammation around nerves. It lowers the threshold of activation, meaning makes those things hyperactive. It can lower it so much that they just fire on their own. So look at the sympathetic nerves or the hypothalamus. That anxiety state is basically your nerves are already, 90% firing, and they're like walking around, their pupils are dilated. Somebody drops a pencil and they jump across the room because their neurons are inflamed. So, that affects your personality.
Yeah.
Well, if you get it in the limbic system, for example, you can have, depression. You get it into all of these areas of the brain swelling. That's why you can see kids with pandas, right? That's like post-strep brain swelling.
Yeah.
Well, they become somewhat psychotic. The kids are acting really, really weird. And we literally can drain it out with our hands. And their personality, I mean, I had a guy in today, he was a guy from Montana and, beard and in his, hunting garb and severe PTSD. And he came back for his second trip. He had a major car accident and some CCI, cervical cranial instability. And I told him, I don't remember the conversation, but he was relating what I said to him. He said, you told me that I would be calmer because you saw all types of stuff in my fight or flight system. And I told you that I had 3 panic attacks getting to see you last time just through the airport stress. He had to go to the bathroom. He was sweating.
Sure.
And he said, and when I flew back, he's like, I was completely chilled, like I had drank a beer,
Wow.
And he's like, it was that different. He said, first thing I noticed was, I wasn't in that state anymore. And we just published a PTSD study in military medicine. We took 13 people with PTSD, late onset, meaning military or first responder,
Yep.
and we had a control. And we did 3 hours of fascial counterstrain on the treatment group and followed them for up to 6 months. And it was 3 1-hour sessions. At the end of that, 12 of the 13 through independent assessment tested negative in the CAPS-5 assessment for PTSD.
Wow.
3 hours of treatment, 6 months later, still tested negative.
That's
So
crazy.
that's psychology.
Yeah.
So the idea that people could have personality changes with inflammation, 100%, because it's affecting the parts of our brain that is our personality.
Yeah. I think my question was more on like, do people have emotional releases during treatment?
I personally, and it's my bias, and I would respect anyone who doesn't agree with me, but I don't think it's in our scope to facilitate that.
Yeah.
As a PT. Okay. So I have a little bit of problem with people saying, "Now I want you to think back," and because I don't feel we should be doing that.
Yeah. Or I just mean like not even like unguided, like
yes,
just
if it's organic, I've 100% seen it.
Yeah.
I just work people through it, but like I know in some cases they're trying to make people in some amount of emotional release.
Yeah.
I think we're getting
I'm not talking about that. I just mean like in general, is that like part of the treatment? It's obviously not part of the treatment.
No, it's not a goal.
Okay.
Yeah, it actually, I've had sexual abuse patients when I did a release in certain parts of the body, they had a flashback. I mean, the moment that tissue was releasing. And, memories have some chemical aspects to them. But I mean, literally one day I remember we were in a conversation and she was half laughing. And when I did a release around her pelvic floor, she just grabbed the table and she had a full blown flashback and it just faded. So yeah. And
it's amazing kind of like what is held in the body and what is held in our tissues and our fascia and all of those things. So yeah. Okay. Very interesting. What else would you like to cover?
Yeah. I mean, again, I think just the take home message here is, first of all, it's an indirect technique. So you find the tender point. We tell you based on the tender point and the process what the release is. It's a shortening and you just hold it. So it's very easy on your hands. It does not hurt. So you can treat children and fragile and chronic pain. You do not have to cause any pain. It should be painless.
Wow.
Okay. So it's indirect, which indirect is a drainage family. It's proprioceptive. It's not a let me force through it family. So all the treatments are backwards. But the reason they work and they have such great carryover, it's getting to that source trapped inflammation. And again, anyone who's like, I don't understand this trap thing, the nutshell of what happens is cytokines. So like if you get hit with a baseball, those fibroblasts and immune cells will release cytokines like interleukin 1B, interleukin 6, TNF alpha. Those cytokines make fibroblasts. First it can shut down the lymphatic pump. That's the first thing it does. Then fibroblasts can differentiate once that pump's shut down. If there's a lot of swelling there, they'll change into myofibroblasts, the contractile type. Then those myofibroblasts start to excrete what's called TGF beta 1, which makes themselves constrict. Well, when does that happen? Like wound closure. The tissue pulls together. But that also happens just around inflammation with the big three, I call them cytokines. So anyway, when that tightening occurs, it can block the pre-lymphatic channels and trap the inflammation. It traps the cytokines. So now you have a positive feedback loop. So the trapped inflammation stimulates the pain receptors. They go into the cord, do all the stuff like muscle guarding pain. So we have to find out where that inflammation is trapped, decompress the tissue to drain out those pre-lymphatic channels. Body pumps it out, breaks the cycle.
I think I saw a YouTube video of you treating someone. I think it was like a class you were doing, but this woman, it was like her whole shoulder was bruised all the way down to her arm.
Yeah, that's one of our before and after shots from the lymphatics class. Yes.
Yeah, it was very interesting.
Yeah. And that picture, it was one session. Actually, Tim Hodges, who teaches my vein class, did that. That was his before and after picture. And he ran out of time at the elbow.
Yeah.
And if
And
you
then
look
you
in the
came back.
picture from the hand down, she's still, she's still
Yeah.
black and blue.
Yeah.
Yeah. And so he
Yeah.
didn't get past his next patient was due. And he's like, I gotta go.
Yeah.
And you
That's
can see where
incredible though, just to see like
just to see it.
how inflamed that was and
Yeah.
how bruised and how like you could literally see the clog.
Yes. Yes. Her right lymphatic watershed was a mess. Yes.
Yeah. Yeah. It was very good. Okay. I didn't
But
mean to
anyway,
cut you off.
so that's how it works. You're going to decompress and hold. It's painless. And the carryover, if you follow the diagnostic process, you don't just randomly poke and treat
Yeah.
because there are plenty of secondary tender points.
Mm-hmm.
Okay. So our process makes you find the generals, not the privates, find the leaders. Okay.
Okay.
Then they're one and done.
Hmm.
You will not treat that dysfunction again unless that patient's completely injured again.
Hmm.
So I like that guy who flew back, everything I did on him last year held. He just got to a plateau, said, hey, I'm better, but I still can't hunt. I want to go even further. I said, come back if I need it. But I didn't do anything I did last time 1 year ago.
Wow.
And that's the norm. So each release is a one and done, but we all talk about the onion. Some people are pretty big onions. You know,
Yeah.
they got a lot of layers.
Yeah.
Okay. But that's the beauty of it. That's what sold me on Counterstrain was that everything I was doing again and again and again, popping this and muscle energy, that. And the first time I ever saw 100% carryover with the treatment was the first Counterstrain things I did. And that's where I'm like, this guy doesn't know totally what he's doing, but there's something to this approach because there were some one and dones even as a novice. I'm like, whoa, that didn't come back. That was crazy. Yeah.
Mm-hmm. Like sometimes we're the best when we don't know exactly.
Oh yeah, yeah, no,
you know, like we're not in our heads, so we're like,
even a blind squirrel finds a nut, as they say, right?
Yeah, exactly. Oh my gosh. Okay, why don't you tell everyone who's listening where they can find the information on fascial counterstrain, where they can find a class, where they can find your articles, all of the good stuff.
Yes, and I would say, first of all, there's a gazillion things out there to train in.
Mm-hmm.
And what I'm trying to build here, number one, when you do indirect over direct, you realize it is the superior way. And anyone who does indirect does not do direct unless they have to.
Mm-hmm.
Okay. So this is full body, all system indirect with a diagnostic process and research to back it up. Okay. Yeah. So that's what I'm trying to build. Okay. So it may not be something you're interested in, but it is the future of where everything's headed.
Yeah.
So like if you're young in your career or you're just like, hey, I'm sick of not having people get better. I'm frustrated. Don't quit. Jump into, it's kind of like AI of the manipulation world. It's the next thing. And yeah, people, they kind of fight it, but new technologies are always, people fight it, but it's where we're headed. Okay. Yeah. And then, if you want to train, it's Foundations of Fascial Counterstrain, and you go to JI for Jones Institute. So the whole Counterstrain website was named after Dr. Jones, jicounterstrain.com.
Okay.
Or if you just Google my name, Brian Tuckey, and Fascial Counterstrain, I'm sure it would take you there somehow. Yeah. And then you want to take Foundations of Fascial Counterstrain, which they call F1.
Okay, great.
Okay.
How many classes are available now?
So again, there are, because some I've had to split into two.
Uh-huh.
So lymphatic and venous, there were so many techniques I had to break it to two classes. Obviously, nerve wasn't one class.
Yeah.
You follow me? And bone, I even had to break. Periosteal bone treatment is the blood supply in and out of bone, which is, bone is cool stuff to treat indirect.
Yeah, that's awesome. Yeah.
So I broke them into two. So it ended up being, there's like 13 classes right now.
Wow.
But as I said, like Celeste, she had a full practice at 4 classes.
Yeah.
Right.
Yeah.
It's just, and a lot of my Counterstrain, people that are caught up, I say in the curriculum, they all kind of joke that it's eventually getting into that latest class coming out. They all have people that they're stuck on and they can't wait. And if I roll out a new class, they all joke it's like a Springsteen concert. It sells out in like 1 hour.
Sure, I imagine. Yeah.
Yeah, because they want the new stuff because, no matter who you are, there's people that have you stumped.
Yeah.
Right.
Okay. I have another question about what is the experience like for the therapist going to the classes? Are they held in hotels? Are they held in
clinics? Clinics. Yep. So clinics. I have, some very generous practitioners who offer their clinics on a Friday. Like I shut down my clinics on a Friday, but they shut down on Friday and we do Friday, Saturday, Sunday.
Okay. So they're 3 days.
They're 3 days. And then, fly back, and people will take 2 to 3 classes a year, usually, although, I've got a guy who came on to work with me, who's one of my TAs. He's learning the brain and he's only been doing it 2.5 years and he's world class because he just said, this is what I'm doing. He actually moved his whole family to one of my other instructors, learned from her. And now he moved his whole family to work for me. He's just that dedicated at it.
Wow.
So, but he did 6 or 7 classes in 1 year.
Mm-hmm.
That's a heavy lift. And you better get out your thinking cap for that one. But I would say 2 to 3 a year is what most people is a great pace. So by the time you start to say, okay, I got these, but I got people I still can't get where I want, you're learning something that you can add.
Great. I went and actually got a treatment with a therapist that's local to me
Awesome.
before this interview.
Yeah.
And it was really interesting. I liked it a lot. I'll be getting more. But she showed me, kind of like the workbooks. I was like, I'm just really interested and I don't want to go into this interview blind. I want to,
Yeah.
tested the waters a little bit. But your instruction manuals are beautiful. Like just so thoughtfully put together. They're so clear, they're so clean, they're so concise. Yeah, I just wanted to point that out that I had a large appreciation for your instruction.
Did she show you the 3D model?
I was really just like skimming it, so I didn't see.
Yeah.
I don't remember that.
So I put on an interactive 3D model, almost like a video game. You can download your course for $99 onto your model, and all the tender points are on the model. You can zoom in, zoom out, peel the muscle, touch the tender point. The release pops up, and you can load all your classes onto your model. It's on your phone.
Wow.
So all the syllabuses are virtual with you.
Okay.
3dcounterstrain.com is something you can do. And so wherever you go, you take your iPad or whatever, and you can just show the patient, okay, your lymphatics, and it tells me arms. So we're going to check these points. You touch the point, shows you the release, tells you what structure it is, and you can layer it up to see what's in that area.
That's really incredible. No, she did not show me that. I just saw the paper manual.
You saw the syllabus, yeah. But it's virtual, so you don't have to carry around your books to grandma's house.
Yeah. That's really cool. I love that a lot. That's, very helpful. Like as a therapist, I just think about being able to have access to that bank of knowledge, or when you're treating a patient and you feel stuck, you could just go and literally look at that and show the patient at the same time, like, here's what we're doing. And
exactly. Yeah. And I use it for, now, of course, people I'm seeing nowadays have already seen a counterstrain journal, but like if you're a male working on a pelvic floor patient and you suspect it's a pudendal neuralgia, you literally can show the patient where the pudendal nerve point is, and it's on the inferior ramus.
Inside. Yeah.
So it's external palpation, but it's on the ramus, the pubic bone. So and you basically can show them release, where it is, why you suspect it, and it's like complete consent, right?
Yeah. So you can do internal work, but external, like, do you have any work that's internal?
I found a way through the referred tender points. Even when we do the deep brain work, it's all external, and everyone stays completely clothed. And again, I designed it that way. I don't want that to be an issue in getting people better. I found a way to do them all fully clothed external.
Yeah. Very good. Very good. That's probably very helpful for some people that would never be able to tolerate the internal work too, or just can't do it. Yeah.
For sure. Yeah. And then, you deal with people with combinations, abuse victims, plus pelvic floor. And, these are people that we might start working in the fight or flight system first to calm them down. And, like I said, you follow what the body tells you, but you gain their confidence. They realize, wow, that person just checked my cranium, knew where it was. The point was before I told them, and they're like, they instantly understand it's medical. You know what I'm saying? So it's like, I've never had a person in my career say no, or feel weird, because it's so medical. Yeah. And I say to the guys, it's like, your mind should be on the anatomy, and women know if your mind's on the anatomy, right? Versus you're being creepy. So like I said, I've never had a problem, because it's like, it's so precise that everyone's like, wow, I trust you.
I just love the idea of the cranial scan and how it is, you can teach that to someone and it's repeatable for everyone. So if I learn it and I do that on 5 people, like I'm going to get, and then you do it as well, like your result,
we'll get the same answer.
You were going to get the same answer.
Yeah.
Yeah. Incredible.
And if you're doing it right, because you find the point that it predicts.
Yeah.
Right. So if it says, it said I should have the visceral lymphatic row in your scan, you go down there and it's not tender there. You got to go back and say, oops, I screwed my scan up because those points weren't there. So you're able to teach yourself in the clinic once you have it, until you're like, all right, now I'm matching the scan. I got it. Yeah.
Very cool. How long does it take for you to kind of pick up the cranial scan?
Well, you learn, the ones in the class, you pretty much have mastered before you leave the class.
Okay.
And we work on the feel of a positive cranial scan in foundations. So when you come to foundations, skills and knowledge and a sample to practice with. That's all it is. But, I had a guy who was in this week as well, who he was telling me how many success stories he had just with foundations. But again, he's just treating regular, sports kids, friends of his daughter, nothing really chronic. But there's power in that class. But, it's not designed to make you take over your practice. It's designed to give you some things to practice the skills.
Yeah.
So, for example, if you want to be a basketball player, you got to practice passing, dribbling, and shooting. That's what we do. And then when you're really good at that, then you can pick up the material so fast.
Yeah.
But we work on, okay, this is the scan for the epidural drainage of the cord. So you go through that, and I want you to try and find one in that, it's between the sagittal suture and the superior temporal line right here. Find me one of those rigid areas, and we check you off. So you said, yeah, I think I got one here, and then we'll come over and double check and be like, yes, that was it. If there isn't one, you're like, I don't think I have one on my lab partner. We'll try and find one, or maybe you're right, they didn't have that. So by the time you leave Foundations, you've already got a feel for a positive cranial scan. And then you go back and you start practicing in real patients, okay, to feel some, not just mild ones like you would find in your lab partner.
Very good. All right. Well, I thank you for your time today. And thank you for all of the hours and hours that you're putting into creating new techniques and to publishing research. I think it's very much needed in this space. And it is the future. So, I mean, it's here now too. So we've got to do it now.
I understand now why very few people do it on both ends, right? You have clinicians, you have researchers, but the best combination is someone who's doing both.
Yeah,
but,
I agree.
There really is, like I said, no one's paid to do both. Does that make sense?
Yeah.
So you've got to do it on your own time, but I understand why so few people have done it. And thank my wife for putting up with me never being around.
Right. Yeah, she needs the credit. You got to make sure you're putting her in the research article.
Yes. Like acknowledgement to my wife who didn't leave me. Yes, for sure.
That is a good thing to have someone backing you up for sure. All right. Well, thanks again for joining us and for being such a willing participant on the podcast.
Yeah. And last thing I'll say is, so probably the quickest thing to read and watch would be the method article. So, and that would be, like I said, if you're say, hey, I might be interested, make sure I don't mess this one up either. But it's again, Brian Tuckey, and it's Fascial Counterstrain, a methodological advancement in indirect osteopathic manipulation. So a methodological advancement in indirect osteopathic manipulation. That was the Journal of Osteopathic Medicine, December 2025.
Awesome. And that do you want to do you have the link for that? If you want to put that in the chat for me, I'll make sure it's added.
Yeah, I'll drop that for you. But that one there's even a video case study of a CRPS patient, bilateral chronic regional pain syndrome, 4 surgeries, saw everybody. And I do the 6 sessions, and I videotape her every session just to show the approach. But it goes through the stasis article. It talks about the problem, talks about how I basically developed the anatomical correlation, even talks about the cranial scan, the whole thing. So that's the what is it article.
Yeah.
But it goes into the phys and a summary that's not too deep.
Okay. I love that. So for everybody listening, we will make sure that these links are in the show notes so they're easily accessible for you all to jump in and just consider if it's
something you want to do. But we need more of us. We haven't blown this up intentionally because there aren't enough practitioners. That's the truth. Okay. Yeah. People say, why didn't I know about this? I'm like, because we don't have enough of us. Look, and they flew in to begin with.
Right.
That makes sense.
Right. Yep. Totally.
So I'm not looking to blow up the patient thing. I'm looking to make sure we have enough of us that we can, take care of all the people that need this work.
Perfect. I love that. And I'm happy to help any of your practitioners. So if you know of any practitioners that are starting their businesses and they need help with that.
Yeah, absolutely.
Send them my way.
I will keep your podcast in mind.
Awesome.
They ask that question a lot. How did you get this to work? Yeah.
Yeah.
But my advice with everyone is, and this is your area of expertise, but for me, what's always worked is, your patients will be your referral source if you're being impactful.
Yeah.
Right?
And if they can find you.
But everybody knows somebody who needs work, right? So if what you did work, they're going to be like, will you see my sister? Will you see my son? I mean, that's what you start. You don't really have to advertise after a while.
Right. And I just want to make sure that those people it's not even really about advertising. It's about making sure that you are set up to make money so that you can stay in business and so that you can really enjoy your life outside of the treatment room.
Correct.
Yeah. Have the best of both worlds. Yeah.
Work balance. Our practice, again, it's the last thing I'll say here, and I'll put the link in for you, but people probably say, do you bill insurance? Well, you can. It bills as manual therapy. But
Mm-hmm.
most counterstrainers are, just do an hour and a half cash model.
Mm-hmm. That's what I love the
And
most.
because people, since it's a finite amount of work, you might only do 3, 4, 5 hours, and
Yeah.
it works or it doesn't work. It's done. It's not like
Yeah.
you got to come for the rest of your life.
Right.
And again, we keep ourselves full because people say, "Wow, I saw all those people, and I only saw that person 3 times, and I'm better." So I actually counted, in case the question came up or I thought of it. I counted, and we have 4 of us right now full time at my clinic, and I've had up to 6 or 7 therapists, but people start their own practices, whatever, and it's
Yeah.
it's not my goal to grow my practice. But we have 4 full timers, and everyone is hour and a half patients, and it's between $190 to $300 an hour is what we're charging. But again, people are $500, they're done. You
Yeah.
follow me? And
Yeah.
we have and
Kind of a no-brainer.
I counted yesterday. We have 112 new patients waiting.
Wow.
Yeah.
Yeah. That's incredible.
Which means we could up our prices, but we don't, because I always say the people who really need us, they're not even working.
Mm-hmm.
Right? It's not, but you can make a living, enough money that you're okay. And then the goal is to enjoy what you do and try and change lives. Right?
Yeah. Yeah. Love that. Okay. Drop me those links for
All right, we'll
everybody
do.
else. We'll see you on another episode of the podcast next week. Thanks for spending this time with me today. If you're a hands-on therapist who is ready to get fully booked and build a practice that actually pays you, I want to help you do that. Head over to heatherhommel.com to find out how we can work together. And if you loved this episode, please share it with someone who needs it. See you next week.